Hi, guys, and thank you for joining and tuning in. My name is Jackson, and I am the founder of The Nurse Break, a platform for Aussie nurses and other health professionals and students to share insights into the careers and experiences in written blog and article formats. You can check these out on www.thenursebreak.org. And as of recent, as you are well aware, I've decided to start some interactive live Q&A interviews so we can hear from our nursing and other healthcare workers across Australia in real time. The Nurse Break is on multiple platforms, and you can connect with TMB on Facebook, Instagram, Twitter, LinkedIn. You can also listen to these interviews as podcasts in your spare time on Podbean, Anchor, and Spotify. I just wanted to do a few shout outs to some organizations and people that I've collaborated with. A shout out to my friend Daniel, the founder of an app called Top Tile. You can download on Android and Apple. You can read all the blogs from the Nurse Break on his app. Alongside the big players like BBC, Mamma Mia, Vogue, The Scientist, if they float your boat. A big shout out to Athel from F Wards. He is an ED nurse and founder of F Wards, an app to help organising your shifts and wellbeing. You can check Facebook by searching FWARDS, F Wards. And a shout out to Osmed. You can read the Nurse Break blogs from all the health professionals on Osmed now, and even document them as CPD, which is pretty cool. We are starting with a COVID-19 series and are looking for any health professionals or any healthcare workers, clinical or non-clinical, to write in 300 words or less, a little piece about their experiences working on the front line. Please check out the Nurse Break website for more details. And guys, if you are watching this live on Facebook, make sure to post your comments and questions as you listen along, and I'll ask my guest. And also, please click the share button so that your friends can also follow along and ask their questions. I'd love to know where you guys are listening from, so also post where you're from. Let's get this show on the road. Hey guys, I've got Simon O'Grady. He is an emergency nurse practitioner currently in Melbourne. Thank you for coming along.
No worries, Jackson. How are you?
I'm good, thank you. So a little introduction about Simon. He was first exposed to healthcare in Ireland as a volunteer first aider with the Order of Malta Ambulance Service. And from there, that inspired him to do nursing, and he worked for a couple of years as a nurse there. And then in 2011, he came to the wonderful land down under and is currently in Melbourne working at a major paediatric emergency department. But he's also worked at a lot of adult specialized major public tertiary hospitals as well. And in his spare time, he volunteers pre-hospital as a nurse practitioner at major events with St. John Ambulance Victoria, and he also works in a nurse practitioner-led GP-like clinic. So, Simon, thank you for coming along. And I did a little quiz for people in my last interview and asked them for some feedback on the first one with Ben. And the feedback I got, three things was: one, don't touch your face, because I kept touching my face. The second one was get a microphone so people can hear better. So I've done that. So hopefully this works. And the third one was start with an icebreaker. So I asked a few people what icebreaker to start with. And I'd like to ask you, Simon, what is your favorite drug?
Nice question. I think my favorite drug probably has to be paracetamol. I think works for everything. It also is easy to take. And I also have to say that it's very underestimated. And also I really like the fact that we're not quite sure how it works.
100%. I remember before nursing, I did a pharmacology degree, and it was quite interesting learning that we use Panadol, paracetamol so commonly, but there's no like agreed on mechanism of action, which is really interesting. Like a lot of the drugs we use, like who knows how they work, but they work. Before we get into some of the more nitty-gritty questions, I'd just like to ask you, how have you been coping with COVID-19? It's so topical. How has it impacted and changed the provision of care in paediatrics, in your view?
So I suppose it's changed our sort of daily life massively and had a great impact on everything we do. So that's been a bit tough. So simple things like going to the gym or going to meet friends and stuff like that. So that's been really hard. It's all been changed to an online platform now. In terms of provision of care for pediatrics, I think one of the biggest things that I've noticed is children are obviously quite scared when they come into an emergency department. And one of the things that we normally do to sort of allay their fears a little bit is give them a smile. But now with the masks that we have to wear every day, that's really hard to actually build that initial rapport with the child, because you're actually wearing a mask, and that can be quite scary for children as well. So that's one of the biggest things that I've noticed that's impacted my care, especially with younger people.
Are you guys doing anything with the masks? Are you like running smiley faces on them or putting photos of you on your chest or anything like that so you can like build that relationship?
We tried drawing some smiley faces on the masks, and they actually turned out to look even more scary than what just the plain mask did. So we quickly abandoned ship on that.
Okay. So how did you get into nursing?
So as you mentioned earlier on, I started off obviously my career in Ireland. If you weren't able to pick the accent, and at the age of sort of 9 or 10, I joined the Order of Malta, which is essentially a first aid organization, similar to what St. John's Ambulance is here, and that's how sort of I got my taste for healthcare and progressed then through the ranks in the Order of Malta up until I finished my schooling, and then progressed on to do nursing at university then.
Okay, very cool. And when you were in Ireland as a nurse, where did you work mostly before you came to Australia?
Yeah, so in Ireland, I completed all of my training in St. James's Hospital, which is one of the largest teaching hospitals in Ireland, and it's based in Dublin City Centre. So I did all of my training at that particular hospital, and then spent about 18 months working once I qualified as a nurse there before I left.
Okay, and that was in respiratory?
Yeah, so initially when I qualified, I started off in respiratory nursing, and then after about 3 or 4 months, I moved to emergency. I think ward nursing wasn't really for me. I think I preferred the variety of presentations, so differences between medical and trauma, whereas the respiratory ward gave me a really good basis for high acuity nursing. A lot of patients there were quite sick. And that kind of gave me my thirst for emergency nursing or acute care nursing, and I thought the logical step to get a little bit more variety in nursing was to move to the emergency department, and that also fitted in well with my pre-hospital experience. So yeah, that was the logical move.
Yeah, okay, that makes sense. So a Bachelor of Nursing in Australia is about 3 years. You can become if you have a degree already, you can actually become a nurse like myself in 2 years if you do the master's version. In Ireland, is it a 3-year course, or do you have to become a midwife as well? What's the degree like? How does it work?
Yeah, so obviously I've never been a student nurse in Australia, but I've dealt with lots of student nurses through the emergency departments that I've worked in. So in Ireland, it's a 4-year course, and it's a honors degree course, depending on where you study. And you come out essentially as what's called a registered general nurse, and that's basically gives you a really good ground level in nursing in all different specialities. So you get a taste of everything essentially. I know in Australia you're not quite afforded that that luxury where you don't get to have a placement in every single speciality, whereas in Ireland I think we get a really broad range of exposure to nursing, different types of patients and different specialities, and it's actually a requirement as a nurse to be registered as a nurse in Ireland is to actually tick off all of those placements like obstetrics, pediatrics, psychiatry, medical, surgical, and those kinds of things. So that's sort of one of the biggest things is the time difference. I suppose the grad year for nursing in Australia, we don't quite have the same type of structure as that. We have what's called a rostered year, and that's built into our undergrad, and it's essentially 9 months where you're paid to be on the wards, and essentially 2 student nurses in their rostered year are equivalent to 1 qualified nurse is how it sort of works. And you're essentially a student that has almost got their autonomous nursing practice, but not quite yet. So you still report to a registered general nurse on the wards and stuff like that when you're looking after patients. So they're kind of the two biggest differences with students, I think, in Australia and Ireland.
Yeah, it's a really big difference, and I get a lot of messages through to the Facebook page, the Nurse Break, and a lot of people want to get a grad year in pediatrics, but they don't have the experience, and they're really worried about. I never did a paid placement. Can I get a job? We can get back to that a bit later, but I guess my next question is, what on earth is an NP, and what areas can nurse practitioners work in?
I think that is a really good question. It's a question that a lot of people have. They see me at bed and I introduce myself as the nurse practitioner, and they're like, sorry, the what now? Or I've got it on my, if I'm doing pre-hospital stuff with St. John, I'll have my nurse practitioner panels, and even St. John members will ask me, oh, what's the difference between a nurse and a nurse practitioner? So a nurse practitioner is essentially a nurse who has completed a master's at university in advanced nursing practice, and you have to tick off specific subjects within that nursing practice masters, and they include a pharmacology module and a health assessment module and a research module, and they have to be core parts of your master's in advanced nursing practice. The other thing that you need to do to become a nurse practitioner is you need to have 5,000 hours of supervised practice in the area of your specialty. And that supervised practice is essentially what allows you to become autonomous in your practice as a nurse practitioner. So when I say autonomous, what a nurse practitioner can do is they see their own patients, they manage those patients independently, as well as collaboratively with their medical and allied health colleagues. And they can prescribe medicines within a certain formulary if they work in Victoria. They can also order tests, and they can interpret the tests that they order. The other things that they can do is they can independently discharge patients. So from an emergency department point of view, I can autonomously see a patient, and they can essentially get the same care as they would with seeing a doctor, but have just seen me and not have any contact with the doctor. And it's a way that nurses can improve their expand their scope of practice, and that bridge the gaps in our healthcare in Australia. So a nurse practitioner is many different things. And in response to the second part of the question, nurse practitioners can work in multiple different areas. So I suppose when you think about the different areas, sky's the limit as to what areas nurse practitioners can work in. I think in Australia, the biggest cohort of nurse practitioners would be in the emergency department, and followed up closely by older persons care.
Aged care, for example. Are there nurse practitioners in aged care?
Yeah, that's correct. Yep. So making a really big impact in aged care at the moment, nurse practitioners, and that's a really big part of the nurse practitioner cohort in Australia at the moment.
Yeah, I read an article recently that a doctor might only go to an aged care facility once a week to see a person, or even less. So I guess embedding a nurse practitioner in there can really promote good healthcare for these really chronically acute, not necessarily acute, but chronically ill people sometimes who are in aged care.
Yeah, and it's about continuity of care as well. That the nurse practitioner is there. They do rounds in the aged care facility every day. They get to know the patients. They get to know the families, and sometimes that nurse practitioner may have done all of their training in that facility. So they've been in that facility for a very long time and get to know all of the patients really well.
Okay, really good advice. Now, you sort of touched on it a little bit, but how does one actually become a nurse practitioner? So do you go through a candidacy, I believe?
Yeah, so initially, how it works is that you become a nurse practitioner candidate, and that's through an application process in your own sort of area. And that candidacy takes it's a 5,000 hour candidacy, and you either come into the candidacy with your masters, or you do your masters as well as your candidacy at the same time. And the candidacy basically provides you some structured education and structured I suppose, reporting mechanisms for your practice on the way to becoming an autonomous practitioner. So,
Hmm.
for example, in the emergency department, when you're a nurse practitioner candidate, you you start off as a very junior nurse practitioner candidate, and your scope of practice is quite limited. So you may only see lacerations or simple broken bones and things like that. And then you report back to either the consultant that's running the shift or the nurse practitioner that you may be working with, depending on who's around. And that's a mechanism for safety, patient safety, and also a mechanism for you to learn I suppose, the tricks of the trade. And then as you become more confident, you widen your scope of practice and the patients that you see, all within a supported environment. And that sort of rounds out your candidacy. And then after your 5,000 hours, or once you're confident in your practice and you want to move on to endorsement, you apply to APRA for your endorsement. And provided that you supply them with the relevant documentation, then they'll stamp your forms and you become an endorsed nurse practitioner.
And on APRA, when you look at it, does it say nurse practitioner, or what does it say?
So it says, when I look at my registration, it says $175 first of all, and second of all it says registered nurse, and then if you scroll down in it, it says endorsement as a nurse practitioner, and
Okay.
it gives you in Victoria, it's a little bit different than other states, because in Victoria we have different groups of nurse practitioners, and they're practiced within a certain area, and there's 7 of those different groups, and then you practice within the group that you're assigned or that you've become endorsed in.
Okay, cool. I guess my next question is, sort of what's the transition from a student to a grad to that career progression? How does that clinical pathway work? So, do most nurse practitioners become clinical nurse specialists or consultants first? And I guess what is the difference between a nurse practitioner and an advanced practice nurse?
Yeah, so that's a really good question. I think the career pathway for a nurse practitioner is a little fluid, I suppose. You can go many different pathways through to becoming a nurse practitioner, but I think one of the main things is that you're essentially an expert in the area that you practice as a nurse, and then you look for that extra bit of autonomy, and that's where the nurse practitioner comes in. So often the nurses that have progressed to senior positions such as CNSs or CNCs in their area, then the next step for them clinically is nurse practitioner. The other area that some people have also come through is the education stream. So they're providing high level education to all of the registered nurses on the floor, or the CCRNs, the critical care registered nurses on the floor, and they want to sidestep from education a little bit and move into clinical practice or advanced clinical practice, and that's where they sidestep into nurse practitioner, and they're the kind of routes that you take. I suppose the difference between a nurse practitioner and an advanced practice nurse is that nurse practitioner has a dedicated and specific framework that you need to accomplish to have the title of nurse practitioner. So you must have your nurse practitioner, your master's, and you must have your 5,000 hours supervised clinical supervised practice. And once you have those and you apply to APRA, it's an endorsement on your actual registration to apply for endorsement as a nurse practitioner. Whereas with an advanced practice nurse, you don't have the endorsement with APRA to be an advanced practice nurse, and that's one of the main differences that you see. And advanced practice nurses come at many different levels. So many times there are nurses who are operating at a really high scope of practice, and they're almost bordering on nurse practitioners. And then you have advanced practice nurses who have maybe done a course in one specific thing to advance their practice in a different area, and that, by virtue of them doing that course, that skill that they've gained from that course entitles them to be called an advanced practice nurse. So everyone's increasing their scope of practice, but I suppose it's the autonomy and the status with the registration body that sort of holds the title of nurse practitioner in such a high regard.
Okay. And I guess when we talk about scope of practice, I've had a few people message me before this that they get a bit confused how that works. So a critical care registered nurse, for example, generally speaking, would be able to manage inotropes and look after a ventilated patient. You know, give or take, they have a relatively similar scope. That might not be correct, but that's my understanding. A nurse practitioner, however, is very specific. So a nurse practitioner could be in aged care, or could be in perioperative care, or could be in mental health, for example. So a scope of practice is not transferable to another area, for example. So you couldn't go to another nursing clinical area if you got bored of ED, for example, and be like, am I still a nurse practitioner? You're going to hire me as a nurse practitioner. Is that correct? Or
Yeah, so in Victoria, there's 7 different categories of nurse practitioner. You can apply for as many as you want, provided you have the clinical experience to back that up. So I actually have 4 notations on mine. So I have pediatrics, critical care, acute and supportive care, and primary care. And they're by virtue of the patients that I've seen and my clinical exposure to those patients throughout my candidacy. And APRA have said that I've supplied enough reference documents and clinical exposure documents to say that I have the skills to be endorsed in those 4 areas. The other ones that I don't have endorsement in are psychiatry, mental health, perioperative, and care of the older person, or aged care. And they're very specific ones in my opinion, whereas the other ones are sort of a little bit more broad, barring pediatrics because that's pretty specific as well. But yeah, so if I wanted to become an aged care nurse practitioner, for instance, I would have to go back and perhaps complete a candidacy, or complete a period of education and supervised practice within the area of aged care to be endorsed as an aged care nurse practitioner. And as I'm speaking for Victorian nurse practitioners at the moment, I think nurse practitioners outside Victoria don't have the specific notations on their registration, and they're just nurse practitioners. Yeah.
okay, that makes more sense. And you said acute supportive care. What is acute supportive care?
Yeah, so acute and supportive care is, it kind of crosses over with critical care. So it's those presentations that may not be critically unwell, but are still unwell and require acute intervention. And that may be things like people who present to private practice who have an exacerbation of their asthma that does not need to be managed in the hospital, or patients that present with acute abdominal pain that does not need to be managed in the hospital. It can be managed in an outpatient setting. And that's sort of where this acute and supportive care comes in.
Okay. Following on from that, I guess, is what is a typical day like for you as an NP in ED?
Yeah, I think by virtue of being, or of anybody working in a nurse practitioner, yeah, as a an emergency department clinician, no day is exactly the same. But typically, an initial day starts off with a huddle, or a gathering of all the staff that are about to start the shift, and that's usually medical, nursing, clerical, and clerical, allied health, and support staff. And we all get together most of the time at the start of the shift to introduce ourselves and find out who we're going to be working with in the shift. After we have any sort of announcements for the day, we sort of break off into our teams for the day. So if you're working in the main cubicle area, you'll break off with the cubicle team and have a chat with them, and discuss how you're going to run the shift. If there's anything you particularly need to get out of the shift, or anything you particularly want to see that day. And it's particularly pertinent when you work in the fast track area. If you feel like you want to improve your skills on fracture manipulation or something like that, then that can be something that, if a patient comes in that requires a fracture manipulation, that person can be involved in the care of that patient. So that's how it starts. And then, as we sort of disseminate into our various areas, you go, and I will pick up the next patient to be seen on the list, and go in and see that patient. If I feel like I can manage that patient completely autonomously, then I will do that from admission to discharge. At the same time, if I feel like I need to collaborate with any other colleagues, whether that is, a medical doctor, it's a social worker, it's a physiotherapist, it's a admitting inpatient team, or it's their own GP, then I'll collaborate with those members of the team to advance that patient's care and move them along through their emergency department journey. So essentially, it's a typical day in the ED for a nurse practitioner is about seeing patients, improving the reason that they've come into the emergency department, and giving them answers, and making a plan of care for those patients. The other thing that's perhaps something that people may forget is that I'm also an experienced emergency nurse. So areas of nursing, if there's a big resuscitation that comes into the emergency department, the nurse practitioner is also an experienced registered nurse or a critical care registered nurse. So they often get pulled to do maybe airway roles in a resuscitation, or circulation roles in a resuscitation, or assessment role in a resuscitation. So we often get pulled to do nursing tasks as well, even though we are autonomous practicing clinicians. We do get pulled to do some of the stuff that we, the way we where we started off our training essentially is as an emergency department registered nurse or a critical care registered nurse. So it's varies different times, different days, but that's the beauty of being a nurse practitioner, is that you cross between the medical and the nursing model, and you get exposure to lots of different things.
It sounds like a really varied profession, or pathway for nurses. And I started the nurse break because we often talk in isolation as health professionals, and the media doesn't do a good job of showing how collaborative healthcare really is. And you'll see, different teams in particular doing certain things that in reality is not what happens. So it's really good to hear you talk about how, you all huddle together. And where I work as well, we have that collaborative huddle halfway through a shift, and the doctors, the nurses, the social, all the allied health will come together. And because at the end of the day, we're one big team. Before we go on, guys, if you're watching live, welcome. Hey, and please comment and put any questions you have. There's been a few of you put some things in. We've got Marion Roche says hello from Plymouth, Devon, England. I don't know if you know Marion, but there you go.
Plymouth, not Plymouth.
Well, there's my ignorance right there. I've got Travis listening in from Perth. Hey, Travis. And I've got a question that sort of follows on a little bit about what we're just talking about, and that's from Athel. How did your role in the emergency department change becoming a nurse practitioner? Did you have a feeling of more or less significance in your nursing team? It's 3 questions. And moving to a nurse practitioner change your level of contribution as a nurse?
Yeah, so I suppose they're really good questions, and really good sort of ways to impact nursing, moving from a registered nurse to a nurse practitioner. So yes, it did have a big impact on my role within the emergency department, and I was going from caring for a specific set of patients in the cubicle areas or the resus areas to moving around to having individualized care and seeing a patient where I am the treating clinician, and I am the one responsible for the care of this patient, and thinking about the planning and discharge for that patient more autonomously than being a registered nurse. So I suppose that's one of the biggest things that changes when you transition from becoming a registered nurse to a nurse practitioner, is that the mindset changes, and the things that become more pertinent change. So when the patient comes in, it's about thinking, is there something that I'm going to miss here that's going to adversely impact that patient, and thinking through all of the diagnosis to rule out anything that's going to impact that patient's care negatively. What was the second part of the question?
That was a long question.
Yeah.
Did you have a feeling of more or less significance?
I think that's a really good part of the question to ask as well, and it's I suppose having a different impact, or an impact that changes your role within the emergency department. So you're moving from an area where you're a registered nurse to a nurse practitioner. So that's obviously one of the most senior nurses in the department. So you're obviously involved in a little bit more of the leadership pathways and those types of scenarios within the nursing leadership team. So in the hospital that I work, there's a nursing leadership team consists of the NUM, who's essentially responsible for running the entire department nursing wise, the nurse educators, the associate nurse unit managers, and the nurse practitioners. And we as a senior group of nurses all collaborate together, and we work together to advance nursing within our department. So whilst whilst I still look after patients clinically, I'm doing it in a different way, but I also impact the direction of the department through the nursing leadership team.
Okay, I hope that answers your question, Athel. Now, what are some of the common presentations that you see?
So
now,
common presentations vary. Yep.
I was just going to say, like, it's a very big question, so just you don't have to say everything that you see.
Yeah, so I suppose this sort of may be prefaced by the scope of practice of the nurse practitioner. So lots of nurse practitioners may have a baseline standard that they meet, but some nurse practitioners have obviously advanced in certain specific areas and have added different areas to their scope of practice. So it depends on your scope of practice as to what patient you'll see. So some nurse practitioners that have just started out may just stick to seeing fractures or wound care or some of the single system injuries or illnesses, and then as you move on, you move into the more complex types of patient presentation. So the fevers, the abdominal pains, the people who are a little bit more complex to work out exactly what's going on, as opposed to ordering a test that will tell you the answer to the question that you ask. You have to think a little bit more broad. So there's lots of different areas that you can areas you can see patients. And I know in our emergency department, the types of presentations that you see are mainly based around the area that you work in. So if I work in the fast track area, you're usually seeing more of the fractures, the dislocations, the wound management, the rashes and those types of things. Whereas if you work in the general cubicle area or the resuscitation area, you're seeing more of the respiratory presentations, the gastrointestinal presentations, the fever presentations. So we're really lucky to have such a wide variety of patients to see in the area that I work in. I know some nurse practitioners who only work in the fast track area, but I think there's a lot of work around trying to get nurse practitioners out into the general population in the emergency department, especially because we are those advanced those nurses that have that advanced autonomy and thinking, and we also have the qualifications to back it up. So yeah, I think we see lots of different presentations, and yeah, it's hard to pick out what's the most common.
Yeah, no, I can understand. And I guess sort of following on from that is there's an app called the Emergency Nurse Practitioner app, and it provides assessment tips and general information for health workers and those with little experience with pediatric patients. Now, I believe you had some involvement in this or as part of a bigger team.
Yeah, that's right. So the nurse practitioner team at the Royal Children's Hospital, we started off with a small pocket guide, which was essentially tips and tricks from all the nurse practitioners and consultants that have sort of given us education over the years from the time that we started in nurse practitioner model that were essentially invaluable to us and everyone that joined the nurse practitioner team. You essentially weren't a nurse practitioner candidate till you had your little pocket guide. And we found that moving with the times, we need to upgrade this and incorporate it into some sort of electronic resource. And then we thought, well, if we're incorporating this into an electronic resource, why do we need to just keep it to ourselves? And so we developed the nurse practitioner app. And one of our nurse practitioners, Melanie Turner, she spearheaded the project with involvement from all of the nurse practitioners and a lot of the consultants within the emergency department, and also in the wider organization, and that they collaborated with us on knowledge and pieces of information to put into the Emergency Nurse Practitioner app. And it's a really good free resource for anybody that sort of is looking after kids and that wants to maybe learn a little bit more about how to manage kids, or you think, oh God, I've been doing this for a long time and it's really not working. Is there a different way that I can do this? Or what's the best practice way to actually hold a child for an examination of their ears or their throat? Or how do I examine a child's dentition? What's the best way to do that? And there's lots of different tips and tricks as you go along, and look through the Emergency Nurse Practitioner app, and they're a really good resource.
Yeah, I've downloaded the app. It is really, really useful, actually. And I guess it'd be quite useful in rural populations as well. I guess for the nurses there with very limited medical resources around. Was that sort of a target audience or?
Yeah, absolutely. So when we started the nurse practitioner pocket guide or the paper form, it was a very highly sought after document. And when we started to see patients and pull out the little pink pocket guide, everyone kind of was looking at us going, "Oh, what's that? How do I get one of those?" And it was really sought after, especially the emergency registrar group that we're rotating from the adult population who wouldn't have
Mm,
as much exposure to the pediatric population. They
mm,
really were looking for it. And the other group, as you said, were the rural and remote nurses who were dealing with pediatrics a lot and having a lot
mm,
of autonomy in dealing with pediatrics. So this gives them a systematic way to assess a child, a systematic way to interpret an X-ray, because children are obviously very different than adults, and it's a really good resource to sort of back them up and show them different areas that they can different ways that they can look through the assessment of a child.
mm. Okay. I don't know if it just lost connection for a second, but I did hear everything you said. I guess following on from that is, do you have advice for nurses without PAEDS experience, worried about the idea of looking after an acutely unwell kid?
Yeah, I suppose there's lots of things that people who healthcare professionals who've never looked after pediatrics before get really scared of, and I think
Mm,
the one of the main things is sort of um, when you look after an adult, it's usually one vial of a medication or one tablet of a medication, and that's standard for that patient. Whereas with kids, that's not quite how it works. So really importantly is knowing your drug calculations or how to work out drug calculations for a child. It's very
mm,
easy to find out the actual drug dose, but to work out the calculation is actually a little bit harder. So knowing how to work out your drug calculations. The other thing that you want to do is engage with the child. If the child knows that you're scared of them, then they're going to be scared of you as well. So making a real concerted effort to engage with the child when you when you come into the room, getting down to their level, having a chat with the
mm,
child first, and introducing yourself, who you are, what your name is, and what the plan will be from here on. Really important as well. Is things like we don't want to frighten children, but telling them things like, oh, I'm going to give you this injection and it's not going to hurt. That's going to get the child completely offside, because obviously an injection is
mm,
going to hurt. So lying to them
mm,
is going to get them completely offside, and you're going to lose a lot of trust with that. So keeping the child on side is really important. Not lying to the child, telling them and explaining to them in their own language what you're going to do, and that's really important. Once you've got the child on side, the parents then begin to trust you, and they sort of see that you're a competent clinician, and you can move on with the care then, because once you've got the child on side, you most of the time have the parent on side, and once you've got that, the battle's
mm.
over. You can keep going with the care of the child. So it's really important to get everyone on side at the start. Getting the child on side can be the hardest thing.
No, yeah, I can imagine. I guess what the advice that I've been given when, if you want to work in PAEDS, the parents are your issue. I don't know how much that rings true, but I guess following on from that is, I've seen a few videos of, I don't know if it's the Royal Children's, but children being given 3D devices to be, transformed into another sort of universe or game while a procedure is done. Is this something you guys do?
Yeah, we did it. We did a trial with the child and life therapists at the Children's Hospital. I think it was probably about a couple of years ago now, and it was about putting 3D, essentially virtual reality goggles on the child, and they essentially got to play a game whilst we did whatever procedure we needed to do. And
Mm,
whilst that, it had some benefits. Some children, it didn't work for some children, and nothing's going to work for all children. So
mm,
it's hard to say that yes, it was 100% of children really liked it, because obviously that's never going to happen. We do have really good, speaking about allied health. We do have really good child and life therapists. They're formerly known as play therapists within the pediatric setting, and they can be really, really valuable dealing with when you're dealing with children in terms of distraction, and using them as a non-medical person to explain to the child what is actually going to happen, and then being with the child as the person who's not in scrubs, who doesn't have a stethoscope around their neck, who isn't going to be doing the medical procedure. They're kind of a person that they don't know, who's going to add to their experience within the hospital, and have a really positive influence on that child.
Yeah. Okay. That's really good advice. Kids are not just small adults. This is a massive question, and we could do an entire lecture series, and I'll ask you to come do that with me one day on all the different anatomical and physiological differences between an adult and a ped or a kid. I guess just generally, what are some of the differences?
So there's a few different groups of differences between pediatrics and adults. So you can look at differences in anatomy, differences in physiology, differences in behavior, and differences in development. And you can look at those things between adults and children, but you can also look at those things between one child and another child. And that's really important differentiation to make as well. That one child, maybe an excellent 8-year-old, and sit there and let you stitch their a hand or their leg up with absolutely nothing, whereas another child might not even let you look at their wound that you have. And it's really important to individualize your care when you're looking after pediatrics. But some of the technical stuff, so in terms of children, obviously they do not have as developed immune system as an adult, and so they become more sick more often. They get unwell more often. They often don't get as sick as adults do, as often as adults do. But we think about things like children having an immune system that's not fully developed yet. We think of children as having an immature cardiac cell, so that when children become unwell, or they become they get a fever or an illness, that the heart rate immediately accelerates. And the reason for that is that the children have an immature myocardium, and that they can increase their stroke volume. So that the way that they increase their cardiac output is that they increase their heart rate as opposed to increasing their stroke volume. So that's one of the things that sort of is really important with children as well, that you can tell a lot from looking at a child from the end of the bed about how they are. The other thing about children is that they often get better really quickly, and that's a really nice thing to see, that when you do some small intervention with a child, and I'm coming back to my favorite drug again, something as simple as giving a child some paracetamol, if they're feeling not quite not so well, giving them a simple drug like paracetamol often can change multiple aspects of how the child's feeling, and that's really important. So that's a really good thing that you can do to assist in with the child, is giving them some pain relief, because often the root of their presentation to the emergency department is some sort of pain.
Okay. I guess following on from that would be, what do you do when a kid can't verbalize to you or talk? How do we navigate, where's your pain, all these sort of things with people who don't talk?
That's a really good question, because it's essentially you bring in the caregivers at this stage. So if it's a child that's a baby that is pre-verbal, or hasn't begun to talk yet, then it's really important to get a really good history from the parents about what symptoms or what behaviors that the child is eliciting that's brought them into the emergency department. And as you become a more experienced clinician dealing with pediatrics, you get to know what sort of factors influence a patient's pain. So, if it's a baby that's drawing their legs up, that's often a sign of abdominal pain. If you see a child that's, pointing to a child that's sort of preschool, and they're pointing to their knee, but their knee exam is completely normal, it's often a pain that's transmitted from their hip. And that's just something, those little tips and tricks that you come across when you deal with pediatrics, that you do, that you pick up, that if you do a knee exam, it's often not the knee that's the problem, it's the hip when they're pointing to the knee. And the other thing is getting really good at your pediatric clinical examination. So examining a patient really well, exposing them for the least amount of time as possible. Obviously, with a young kid, you don't want them exposed for a long periods of time where they can get quite cold. But exposing them to see what you can find when you expose the child. And the other thing about children is that often, if you watch a child for long enough, you will find the root cause of the problem. So if you admit them for observation, which is obviously different than adults, because adults can tell you, I have a pain, it's right here, it comes when I do this, it gets better when I do this, and it's much easier to figure out. With children, they don't often know what makes the pain worse. When does it come? Does it come after eating, and those kinds of things? So often a period of observation is a really good diagnostic factor for making a good diagnosis in a child. So that's one of the main differences as well, that things are just a little bit slower in pediatrics, and you have to give the child time as opposed to an adult where they can just tell you everything that's happening.
Yeah, really good to hear that. I guess sort of a different topic is what are some of the common misconceptions about nurse practitioners, and from the public, but also within the healthcare community? And I guess, what are some challenging aspects of being a nurse practitioner? I know it's a heavy question.
Yeah, I think there's lots of different factors in that question. I think the misconceptions are not really. I think the misconceptions stem from a lack of knowledge, I suppose. A lot of nurse practitioners, because there's not as many nurse practitioners in the country as nurses or doctors or physios or OTs or that kind of thing, then obviously the publicity around nurse practitioners isn't as wide and as far-reaching as those professions. So it's a relatively new profession within the healthcare model, and I suppose the misconceptions or the questions that people get are, oh, who are you, or what are you, or why do I not need to see the doctor, or that kind of thing. And it's just about educating those people, and once they have the education, most of the time everything just flows on from there, and they understand the role. And once people understand the role, you normally don't come up against any challenging behaviors or anything like that. So I suppose once you provide people with that education, then that's the I suppose the winning factor in terms of caring for the patient. Because if they find out that they're going to get exactly the same care, or they're going to get the same collaboration of care, then they don't have a problem with that.
Okay, yeah, I can see there's a lot of aspects to it. I guess my next question is, because we're sort of pressing time here, is what is the best piece of advice you've ever gotten, or you would give to anybody, another nurse?
Yeah,
Not anybody.
Not anybody. I think one of the best pieces of advice I can give people is to speak up for your patient if you think your patient is unwell, or you're finding something that's not quite right with your patient. If you can't put your finger on it, then escalate it and do everything that you can to sort of speak up for your patient. And essentially, you're the person, if you're the registered nurse, you're the patient that's with the patient most, and you're the patient that's looking after them often for 3 or 4 shifts in a row. If the if the patient is on your ward for that amount of time, or if the patient's in your emergency department, you're the nurse that's checking in on them once or twice an hour, and you're the person who's seeing the trends in how this patient is progressing. And that's really important, especially in the pediatric setting. You go in and see a patient, and I might see a patient as a nurse practitioner for probably 15-20 minutes to do an examination, and then I move on to the next patient. I put in my plan of care, and then I might come back to them in an hour or 2 hours time to see how they're getting on. But in that time, the nurse or the registered nurse has been in and out to that patient multiple times. So I'm really relying on that registered nurse that's looking after that patient to tell me that anything that they've noticed, or if their vital signs have begun to deteriorate, or if their vital signs are improving, or if they've you've seen them and they because I've stuck a speculum in their ear to check their ears every time I come in, they huddle up to their mom and they don't want to leave their mom. But because the nurse has come in and brought them an icypole and has been hasn't stuck things in their ears or down their throat, they're much more friendly with them. So giving the treating clinician that advice about when you go away, they're actually much nicer. Yeah, I think that's really important, is speaking up for your patients, and don't be afraid to speak up if you feel like something's wrong. So I think that's one of the best pieces of advice.
I think very sound advice. I've got a funny comment here that someone's posted. I think it's your father.
My
Hi, I'm
dad.
an EMT in Ireland, and I taught him all he knows. And I got a question from Kate Styles before we get to some other questions. Is how do you find being a nurse practitioner in the pre-hospital setting? #St. John.
Yeah, love it. Awesome. Great question. And I suppose plug for nurse practitioners with St. John here. There's currently 2 registered nurse practitioners in the country of Australia. So I am number 2. And shout out to Ange, who was the first ever nurse practitioner endorsed to practice with St. John. Go Ange, paved the way for me and made it a lot easier. But I really enjoy pre-hospital work, and I have since I was 10. And that's sort of where I found my healthcare niche, and that's really it's really allowed me to have not only a great clinical opportunity, but also as with any organization like St. John or the Order of Malta, it's great to have such a great group of a social group to chat and to educate and those kinds of things. So yeah, love being a pre-hospital NP, and potentially it's way of the future.
And I guess you just mentioned education. Do nurse practitioners have a massive role in education for staff?
Yeah, so I suppose at the end of the day, you're still you're still an advanced practice nurse, so you still have that higher level of knowledge in multiple different aspects, and there's multiple different ways that nurse practitioners can educate staff. Often it's on the floor education about assessment and teaching people on the floor how to assess a child's, say, neurovascular status for an arm, or exactly what nerves you're testing when you look at neurovascular status. The other way is that we often get pulled in for formal education, and I know that I do some education for postgraduate critical care nurses on the topic of pediatrics. So through universities, we obviously get recognised for a lot the width and breadth of experience that we have, and that's sort of one of the other ways that we do. So both formally and informally, education is part of our portfolio, I suppose.
Okay. What does the future of nurse practitioners in an Australian healthcare system look like in your view?
Yeah. Okay, well, we need lots more. So any budding nurse practitioner out there, go for it. I think we're widening our scope in the different areas that we're practicing in. So if you are perhaps a nurse practitioner that's looking to move into a new area of practice, then that's a really good idea. And there's lots of people who can help you progress your candidacy in that area. And those kinds of things. So I think nurse practitioners are going to become a lot more familiar to a lot more people. They're going to become a lot more widespread, and they're going to become a lot more well known for the work that they're doing, because there's a lot of nurse practitioners doing really groundbreaking work at the moment in lots of different areas.
And they'll have to come on here and I'll interview them. But yeah, it's really good to have to showcase through this interview as well. I guess that was sort of the purpose of this. I've got 2 simple more questions for you. What is next for your career?
Yeah, so it depends on who you talk to. If you talk to one of the NPs at the Children's, she thinks it's PhD. I'm still toying with the idea. It's not a task you enter into lightly. So I think currently it's continuing to expand my scope of practice, working in private practice and expanding that scope of practice, and then perhaps maybe in the next who knows how many years looking at doing something with a PhD, but that won't be for another while yet.
Okay, and can you, just before we get to the last question, was that GP clinic, sorry, not GP clinic, the nurse practitioner-led clinic, that's another role you have. What is the nurse practitioner's involvement in that, and how does that all work?
Yeah, so it's a privately run nurse practitioner clinic, and it's a really good opportunity for nurse practitioners to practice autonomously. And it's an emergency clinic that deals with minor injuries and minor illnesses. So anyone can rock up to the clinic, and essentially it's an out of hours clinic that you can essentially it's attributed to something similar to a GP clinic that's out of hours. And we can autonomously manage patients, provide prescriptions, provide procedures, and those kinds of things. So it's essentially like going to see your GP, but instead you're seeing a nurse practitioner who's going to provide you with similar care and similar collaborations with other healthcare professionals. So it's a really good opportunity for nurse practitioners to expand their scope, and also for patients to access care.
And I know you may not like this question, but how does Medicare and nurse practitioners, how does that blend together?
Yeah, so it's a bit of a topical question at the moment. And Medicare, so nurse practitioners can bill Medicare privately. The Medicare billing is somewhat less than the billing that a GP, say, for instance, could bill Medicare for. And in some instances, it's providing similar care. So there's an actual task force that has been set up by the Department of Health in collaboration with the Australian College of Nurse Practitioners to look at that at the moment. And I think their findings should be coming out. I think the latest update I read is around the middle of the year, and that will be recommended to the Department of Health and looking at Medicare reform for nurse practitioners, which will be a great step forward for the profession.
Okay. That sort of sums that one up. Hi, Michelle. Awesome. You must work with an amazing team.
Favorite colleague.
Oh, really? There you go. And amazing. So inspiring. So really good that you've been inspired. And my final question is, what advice would you give to someone wanting to consider to be an NP?
Yeah, I think it's an absolutely brilliant pathway to follow if you're really interested in it. It's something that gives you job satisfaction no end, and I think the main thing to do is just go for it. If you feel like NP is the pathway for you, absolutely just go for it. Get your master's done, and then speak to your workplace about getting your candidacy off the ground, and really go for it and hit the ground running and take every opportunity that you can. It's definitely a really worthwhile pathway to go down.
Awesome. Final words. Guys, if you've been watching this, thank you for watching. You can still post your questions and comments and interact with it. Maybe Simon will be able to answer them in the future. Also, if you guys have listened to this on Spotify, not the live recording, then thank you for listening. Everyone who is currently listening, these will all be downloaded as podcasts as well. So you can watch them on Facebook and I think YouTube shortly. And you can listen to them in your long car trips if you really want to on Podbean, Anchor, and Spotify. Thank you, Simon, for joining me at 5:30 to 6:30 on a Friday night. I think it's takeaway time, and it'd be
definitely takeaway time.
Definitely takeaway time. Okay, I'll leave you with it. Thanks, Simon.
Thanks, Rex.
Thanks.